Okay, so thank you very much to Dr. Ronco and the organizers of this meeting for the opportunity to talk about this. I'm going to take a little bit of a detour from the previous presentations in the sense that I'm really not going to talk about novel therapies. I'm going to talk about maybe novel approaches to solving or managing this condition. So I think, you know, as a Canadian, I tend to be a bit of a rationalist in terms of delivering healthcare, and I think when you're thinking about contrast nephropathy and looking at the existing evidence base, there's a couple of caveats to anything that I'm going to say right now. The first is that most of the data that we have about this condition is really based on intra-arterial administration of contrast in the setting of cardiac catheterization. So as to whether these interventions are applicable to patients who receive intravenous contrast in the intensive care unit, I think is debatable. There's certainly some controversy about the clinical importance of contrast nephropathy in patients who are receiving intravenous contrast. So most of my discussion is really based on intra-arterial contrast in patients undergoing cardiac catheterization. So if you're thinking about that, I think you need to think about acute kidney injury in the context of the risk of the procedure versus the potential benefit of the procedure for which they are receiving the contrast. And I think that, you know, current approaches, while, you know, there's certainly some novel and interesting therapies that are being proposed to prevent acute kidney injury, we do have a fairly solid evidence base for a number of interventions. And I think current approaches need to use that evidence base. I think as researchers, I don't think we necessarily do the best job in terms of translating the findings of our clinical research into practice. And there are often very practical obstacles to delivering some of the therapies that we study. Intravenous fluid is one of those, so certainly in my center, giving 6 to 12 hours of intravenous fluid around a catheterization procedure is not necessarily practical when patients are being transported between universities or between wards. So the third point I'd like to start with is just to say that prevention is not likely a single intervention. It likely requires a number of interventions bundled together, and that's sort of where I will take this talk. So in terms of weighing the attributable risk versus benefits, I think as all of us as complications associated with it, with the benefits from the imaging procedure. So, you know, in cardiac catheterization, that's perhaps a little bit easier, I think, when you're not dealing with the cardiac catheterization. We often kind of wonder whether we should be using contrast or whether alternative imaging procedures are available. Once we've made the decision, there's certainly been a lot of conflicting data about what kind of fluid to use, how much fluid to use, whether we should be using N-acetylcysteine, and often we just kind of give up our hands in frustration and try everything on every patient. In terms of cardiac catheterization, I think, you know, when you're talking about benefits, I mean, obviously the patients at highest risk of developing this complication are those with chronic kidney disease. And certainly, unfortunately, many of the cardiology trials have excluded patients with significant chronic kidney disease, but certainly the ones that have included them would suggest that there is benefit to treating these patients aggressively with intervention, both in terms of the outcomes of death as well as the outcome of subsequent myocardial infarction. So, you know, this is a nice bit of work that's done by my colleague Matthew James at the University of Calgary, where it sort of weighs the risks and benefits of potentially developing contrast nephropathy in the setting of cardiac catheterization. And while these patients with significant chronic kidney disease do have an increased risk of acute kidney injury, that is outweighed by the benefits with regards to mortality in patients who do receive an intervention, as well as, and with really no incremental risk in terms of developing end-stage renal disease. So, you know, while you have to weigh the short-term risk of acute kidney injury in any patient, certainly these patients are likely to benefit with intervention. Further, there's certainly significant benefits for patients with chronic kidney disease with regards to health-related quality of life. So again, more work from our group at the University of Alberta and the University of Calgary. We were looking at patients who had quality of life assessments, and as you can see on it's quite a small, the writing's quite small, but essentially if you stratify by GFR and the type of intervention, patients with the highest quality of life are those that receive coronary artery bypass surgery and PCI versus those that are treated with conservative management alone. So again, an additional argument to suggest that we really shouldn't be shying away from considering interventional procedures in these high-risk patients. So many of you are familiar with this concept of renalism, which suggests that our patients with chronic kidney disease are often undertreated. So again, this very nice sort of summary table would suggest that patients with chronic kidney disease are vastly undertreated with regards to offering of coronary angiography. So almost, in some cases, a 50% reduced likelihood of receiving angiography despite being very, very high-risk patients. And likely, based on the previous evidence, this is probably not appropriate. So let's talk about risk prediction in contrast for contrast nephropathy. This is a nice systematic review that was published in a Canadian journal earlier this year. And it really summarizes very effectively. I don't want you to read this particular forest plot, but just to say that there are over 75 risk prediction models that are currently published. But only 7 of those have actually been externally validated, and only maybe 3 or 4 of them have reasonably good discrimination. So all of them, as I said before, pretty much describe patients who've undergone cardiac catheterization. So again, the applicability of these to patients outside of that context is difficult to ascertain at this point. The interesting thing is that inclusion of peri-procedural variables didn't really seem to affect the ability of any of these externally validated discrimination tools in terms of predicting contrast nephropathy. And certainly, in terms of what these prediction tools predict, certainly they're most powerful in predicting dialysis requirement and not lesser forms of acute kidney injury. So that is also something to keep in mind. Not surprising, chronic kidney disease is the most powerful predictor of contrast nephropathy, with the other ones being age, contrast volume, a history of heart failure, and diabetes. And so when you summarize all of the available risk prediction models, those are really the top 4 variables that come out. So risk stratification is an important part about, I think, an important step in terms of weighing risk-benefit for the patient. So what preventative measures are there that are available that have a fairly robust evidence base for which we can recommend specific interventions? I would argue that there are really probably only 2. One is related to contrast volume specifically, although there is some, we have fairly good evidence base about types of contrast as well. And the second is hydration. So both the type of hydration and the volume of hydration. And both of these have been fairly extensively studied over the last decade or so. In terms of contrast type, to remind you, obviously, high osmolar agents are usually in the range of about 1,400 milliosmoles per liter. Low osmolar agents are in the range of 700 or 800 milliosmoles per liter, and isoosmolar agents are obviously in the range of about 300. There was certainly a lot of interest in looking at the osmolality of these agents in the early 2000s, with the idea that these hyperosmolar agents were perhaps more nephrotoxic. Certainly recent systematic reviews would suggest that the difference between isoosmolar and low osmolar agents are probably not as significant as we thought. Perhaps the type of osmolar agent is more important than the osmolality specifically, and this is kind of a nice demonstration of how, so on the, the left-hand panel is a comparison between iodixanol and iohexol with an obvious reduced risk associated with iodixanol use. But when you actually compare iodixanol to low osmolar agents on the right-hand side of this panel, you see there's really no significant difference. So contrast type is probably not as important as we thought it was, although certainly certain specific types of contrast may be associated with osmolality may not be as important, but certain types of contrast may be more highly associated with contrast nephropathy. What about contrast volume? There's been a lot of interesting work done trying to sort of estimate what the safe amount of contrast is to provide that you can provide to a patient. So Siguroi was really the first sort of investigator to look at this and then very nicely describe the association between contrast volume and acute kidney injury in about 115 patients, and then came up with this maximum contrast volume limit of about 5 mils per kilogram normalized to serum creatinine. And since that time, a number of other studies have tried to estimate what that maximum contrast limit might be. And I think this is, and as we move forward, I think this is an important sort of addition to our current knowledge base in this area. What can we say about contrast volume reduction? I think this is an interesting study that was published in 2014 that looked at the use of automated injectors. So prior to that, much of contrast volume was just injected manually, and much larger volumes of contrast were used. With the advent of automated injection, there was a lot more precision in terms of the delivered contrast. And this very nice study sort of summarizes the significant reduction that you can achieve in terms of contrast delivery if you're using an automated injector versus just manually using contrast. And so again, so the subgroups in this particular slide look at diagnostic versus interventional angiography with significant volume reductions in the range of 40 to 50 mils using an automated injector, which is not inconsequential. This also resulted in a decrease in the observed incidence of contrast nephropathy in all of these populations. So again, further corroboration that there probably is a safe limit for contrast and that reducing contrast can effectively reduce the incidence of contrast-associated acute kidney injury. And using automated injectors would be an important part of that. What about intravenous fluids? There have been many, many studies now that have looked at intravenous fluids, compared types of fluids. The Poseidon trial is provides a nice sort of practical approach to fluid administration in the context of particularly of cardiac catheterization. And in this particular trial, patients were randomized to sort of a maintenance IV infusion of about 1.5 mils per kilo per hour versus a very hemodynamic guided fluid administration where there were fluid loaded up front, an LV-EDP was measured, and then patients were given additional fluid depending on their left ventricular and diastolic pressure. And the study nicely showed that by being much more guided in terms of fluid administration, they were able to reduce the incidence of contrast nephropathy fairly significantly, no matter how it was measured, whether using a 25% increase in serum creatinine or an absolute number, showing that, that you could be a lot more precise in terms of your fluid delivery. What about type of fluid? There was a lot of interest after the Merton study in switching to intravenous bicarbonate versus using normal saline. In many centers that is problematic because of the cost differences between providing those two types of fluids. And when you actually look at a sort of summary effect estimates of the studies, it's very interesting to see there's quite a bit of bias in terms of publication. So if you look at the published studies, there was certainly evidence that bicarb might be of benefit as compared to normal saline. When you add unpublished studies to these effect estimations, you can see that, in fact, there doesn't really seem to be any significant difference between using saline or bicarbonate. And in fact, when they were looking at differences between the studies that favored bicarbonate versus those that did not, certainly publication year, the size of the study, the number of patients in the study, and the quality of the study all influence the results. So in the end of the day, it is likely that there's probably no significant difference between using bicarbonate versus saline for the prevention of acute kidney injury in this context, with potentially cost savings using normal saline. And of note, the Poseidon trial did use normal saline in that trial. What about N-acetylcysteine? So, despite multiple meta-analyses, 2 of which came from our center alone, there has been ongoing controversy about the benefits of N-acetylcysteine for the use for prevention of contrast nephropathy. And you can see most of these meta-analyses have been inconclusive. The ACT trial, which was published a few years back now, was certainly the largest and best powered study to address this question. And certainly they, in that particular trial, which included 2,600 patients, they were unable to detect any difference between patients who were treated with N-acetylcysteine versus those that were not. Nor did they see any difference in the requirement for dialysis or any of the hard outcomes, such as death or cardiovascular death. The study authors went on in the same paper to analyze previous studies evaluating N-acetylcysteine and nicely pointed out that the positive trials for N-acetylcysteine were often unclear with regards to allocation concealment and also had significant methodological difficulties. So certainly the evidence until this point would suggest that N-acetylcysteine probably doesn't really make a difference, although certainly there are, given that it is fairly benign, it's still relatively commonly used. There is an ongoing trial, a multinational trial that's being led by Stephen Weisbord in the United States that will hopefully definitively answer this question, although I think many of us feel that the question has already been definitively answered. So in terms of an evidence summary, I think we really don't know much about contrast nephropathy outside of cardiac catheterization. We probably undertreat high-risk patients because of this fear of acute kidney injury without really thinking about the benefits to the patient in that particular circumstance. Fluid works. It probably doesn't really matter what kind of fluid you use, and certainly hemodynamically directed fluid therapy is perhaps the safest option for the patient and the most pragmatic way to deliver fluid. Contrast is bad, and certainly the more contrast a patient receives, certainly the higher the likelihood that they develop acute kidney injury. So how do you put all of this information together? So I'm just going to talk for the next couple of minutes about an intervention that we've been able to implement in the province of Alberta, where I work. And so we are lucky. So we are able to do population-based interventions because there's really only 3 sites in the province that do cardiac catheterizations in a province of 4.5 million people. So this is work that's being currently undertaken by Dr. James and myself. In terms of using clinical decision support to try and reduce the risk of contrast nephropathy. So, the case that we've used is primarily a financial case. So, at the present time, it costs our government about $10 million a year to deal with the acute complications of contrast nephropathy in the setting of cardiac catheterization, and about $1 million a year to support all the patients that require chronic hemodialysis as a consequence of developing this complication. So it's a pretty good financial argument for an intervention. So we were borrowing from the work of Jeremiah Brown, who published this very nice paper in 2014 describing the outcomes after implementing quality improvement interventions in a number of hospitals in New England. And what he was able to do in this paper was describe how he identified several benchmark hospitals that had very low rates of contrast nephropathy in the range of 3%. And then using a number of focus groups and iterative quality improvement interventions, was able to reduce the overall rate of contrast nephropathy in the other hospitals. So again, a successful demonstration of just using quality improvement to reduce contrast nephropathy rates. What was interesting was to see what worked and what didn't work in his study. And what didn't work was the use of things like checklists. Just simply using checklists is probably insufficient in terms of really having a sustained difference in care delivery. What did seem to work were the use of an EMR, so obviously it's a systematic way of gathering data, flagging high-risk patients, and reducing and developing effective methods to reduce the amount of contrast volume that was received by the patients. And so we were kind of borrowing from some of the work that he did in terms of designing our own intervention. So our intervention really has 4 stages. The first is really to come up with an automated risk assessment for all patients. So we have an electronic medical record. All patients undergoing cardiac catheterization have their information input into the Approach database. This is a provincial and national database in Canada. So given that information, we could then, we could go forward and calculate, risk stratify patients and calculate what a safe dye limit might be. We could optimize their fluid therapy or give specific recommendations based on risk, and then have a very specific follow-up plan for these patients. So risk stratification is a really important part of our quality improvement measure, because certainly not every patient requires sort of enhanced care or an alternative care pathway that may require more intensive monitoring. So being able to adequately identify patients at highest risk is important, but it has to be done in a way that's usable and accessible to clinicians and that is linked directly to a specific intervention. So many of us have worked on risk models, including myself, that look something like the little picture there on the left. But in order to translate that into something that clinicians can use, we have to be able to provide information in a meaningful way. So what we've been able to do is be able to give specific risk calculations at the time of booking of cardiac catheterization that will calculate a risk of both contrast-related acute kidney injury as well as a risk of dialysis, and use a color-coded flagging system, say, with red for high risk, green for low risk, yellow for intermediate risk. And then we've derived our own risk calculators that are specific for our own population. And once we have that information, we've also, we felt that it was important to also include some recommendations with regards to safe contrast limits for any individualized recommendations for our patients. And what we did see, and this is these are the 3 centers in our province that do cardiac catheterizations, and what we did see was really no difference in terms of the volume of contrast that was administered in low-risk patients versus high-risk patients. So there was certainly room to move with regards to giving more directed guidance about the amount of contrast that we were giving these patients. So, so this risk table is able to provide some of that guidance, in terms of giving a concrete volume target for any individualized patient, which is then given to the cardiologist who's performing the catheterization. Obviously, the important thing to note is once you have a fairly high risk of developing contrast nephropathy, the safe volumes for contrast become lower and lower. I've been assured by my cardiology colleagues, though, that they can do diagnostic casts with 30 to 40 mils of dye and PCIs with less than 100 mils of dye, which is often well below some of the limits that are set out in this particular table. So once the patient has a risk calculation, as I said, the cardiologist is given specific information about what amount of contrast they can use, as well as directed information about the procedure itself. So biplane angiography is often a technique that's used at our institution to reduce the amount of dye that is required for a procedure. So making suggestions about the type of angiography to use and to not do left ventriculograms, for example, give specific guidance to the cardiologists. And all of this work has been done in collaboration with our cardiology colleagues at both centers. So in addition to giving specific individualized recommendations about contrast volume, we're also able to give very specific recommendations about fluid therapy, again, using some of the results from the Poseidon trial. So the recommendations that we have provided are that, and certainly in patients that are flagged at high risk using our risk prediction rules, that they are given fluid as recommended per the trial. So an initial volume load and then directed hydration based on their left ventricular end diastolic pressure. So this information is given to the cardiologist as well at the time that they, again, are doing the catheterization. So just as important as the interventions that can be provided sequentially that are specific to the patient, I think we feel that follow-up is also an important part of caring for these patients. And so this is an example of a chart report that is generated and put in the patient's chart after a procedure where their risk is flagged and all of the recommendations and guidance is also flagged. In addition to that, all the cardiologists are actually provided information about whether or not they've adhered to the recommendations. So a process of audit and feedback is given to each individual cardiologist to give them information as to how adherent they've been to the recommendations. And again, this has certainly been proven in other interventions to improve adherence to quality improvement measures. Finally, follow-up for the patient. So the cardiologists are given this audit and feedback, but the patient is also given information about the procedure, their risk of contrast nephropathy, the requirement to have lab work done post-procedure, and to follow up. In addition to that, their family or their primary care physicians are also given information, again, with regards to their risk for the procedure that was done, and their requirement for follow-up. So we feel like that by using a very specific and multiple interventions of this type, both in terms of risk prediction, in terms of specific patient-specific interventions, as well as thorough follow-up, that we're able to close the loop in terms of and sort of address all the opportunities to improve care for our patients. So I think the key to effective implementation of any type of quality improvement measure is really to link guidelines or recommendations to specific treatments and to make sure that it's part of the clinical workflow. So while there are many risk prediction rules floating around, it has to be easy for the end users or the caregivers to be able to use and implement the information that we have for them. So in terms of final thoughts, we certainly don't have this silver bullet to prevent acute kidney injury, and certainly this is not to say that we shouldn't continue to try and to look for novel and new therapies in this area, but we certainly do have a fairly robust body of evidence that we can use right now to improve the care for our patients. And I think systematic implementation of known low-risk and inexpensive interventions is a practical approach to this issue at this moment. Certainly, more research needs to be done in terms of how effective this approach is, and we'll certainly be able to give you an update on that in a year or two. But also, the whole area of acute kidney injury outside of cardiac catheterization associated with contrast is also, I think, an area that we don't know a lot about at this point in time. And that is all. I'd just like to acknowledge some of the people that support the work that we do are doing in the province of Alberta.